Welcome to the Pod of Inquiry, everyone, the podcast for human optimization and understanding. My guest today is Dr. Erin Nelson. Erin is a lower extremity peripheral nerve surgeon from Ames, Iowa, and I have been a huge fan of hers for several years now and have watched her come up through the ranks of the Association of Extremity Nerve Surgeons. She's going to present a case, and we're going to talk about hydrodissection, and this is a really important episode because it is a situation where you can see how a nerve actually improves with neurophysiological testing, or EMGs in simpler terms, after this procedure has been done. So we talk about hydrodissection and some of the aspects of D5W infiltration. So I think you'll learn a lot about hydrodissection, D5W, and just some general concepts of nerve that we discuss in this fascinating conversation. So please enjoy this episode.
Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
All right, I've got Dr. Erin Nelson, who is a very good colleague and friend of mine, on today. And welcome to the Pod of Inquiry, Erin. Thanks for taking the time to come on. We're going to talk about something that you and I have been playing with for a while now, and that's hydrodissection. I don't know, it's been a while since you started doing hydrodissections. I know you came down to Atlanta to hang out with us a little bit, and we had some fun. But since that time, you've been really getting into this, and the case,
I have.
So the case you're going to share with everybody in the audience today is really one of the first, in my knowledge, and I just as I was telling you before we started recording, I have not had the opportunity to do a complete literature search yet, but what you're going to present today is actually very unique and very compelling, because hydrodissection, as you know, is relatively new here in the U.S., albeit it's been around in Korea for like 30 years. So we're a little bit slow to the switch. But anyhow, so tell me a little bit about, before we get into this specific case, tell me a little bit about what your thoughts are on hydrodissection and what it is, so the audience understands what we're doing here.
Yeah. So, hydrodissection is essentially injecting 5% dextrose around the nerve at the points of entrapment. And there's described areas of the points where nerves will travel through tunnels, and known to be points where that nerve can either get swollen in that tunnel, get injured, aggravated, that type of thing, to kind of create painful symptoms. It can also lead to weakness or chronic pain, CRPS type 2, things like that can be where it progresses to. So hydrodissection has benefits to try to treat that underlying entrapment by injecting around that nerve, ultrasound-guided, to alleviate that pressure and entrapment on the nerve. So how I describe it to patients is it kind of, we'll say, stretches that tissues around the nerve when you're injecting to give it a break from feeling that pinch, which essentially when we're doing our nerve blocks, kind of what they do as well, to give that nerve a break from feeling that pain. And then that dextrose provides energy to the cells around that nerve, provides that nutrients if it gives it that break from the entrapment from that vasa nivorum and nevi nivorum, from not getting the nutrients to the nerve. So giving that alleviation of that pressure, the nerve can get back what it needs to essentially, we'll say, heal, for lack of a better description.
Yeah, so you gave us a lot there. It's like when I ask for a glass of water and they turn the fire hose on me. So let's unpack what you said there, because I think there's a lot of people that are interested in hydrodissection, and I'll get some questions like, well, can you do hydrodissection with saline or local anesthetics? And the answer is yes, you can, because by definition, I would think you could safely say that hydrodissection is, as long as you're putting in some type of a fluid, you're creating a mechanical effect. But you want to tell people why we prefer D5W over the other agents?
I mean, I think just a little bit of that kind of the theory of like some like lycopenia, where some of that might be reduced around that nerve, creating some of the symptoms So giving that dextrose can be a source of energy and kind of increasing that glucose that the nerve needs.
Right. So people have to understand that when a nerve is focally entrapped in one of these tunnels, like you pointed out, that there's a process that goes on that interrupts the cellular mechanisms at that level. And one of them is the glycopenia or decrease in glucose. So then I get another question a lot of times, and people say, well, and the patient you're going to present is a diabetic patient. And they'll say, well, what about injecting dextrose 5% in water in a patient with diabetes? Is that okay and safe to do?
Yep. Yeah, it is. And so they're not seeing that spike of their blood sugar is going up. And I think you get more from a steroid injection than you do from the dextrose, at least.
Yeah, no, I've never seen it spike anybody's sugar. I think that because of the amounts, even though we're using sometimes 30 to 60 cc's, I've never seen that happen. What about the other properties of D5W that, I mean, there's a lot of physiology that's going on with that particular substance versus something like just saline. And one of those is the substance P, which is a mediator of pain. And so that could be a pretty rapid, response based on, the patient will, a lot of times the patient will tell you why you're doing it. At least I've heard this, like, oh, it feels better already. So I'm not really dialed in on to the exact neurophysiology that's causing such a quick response, but some of that has to be in addition to the mechanical separation of the entrapment, the glucose, because, it's kind of like oxygen. You kind of need it,
Right.
and, so that's, and you don't get any of that effect with the saline. All with the saline, the only thing you're getting is just this expansion or separation of the surrounding tissues from the nerve. So, so I guess the answer to everybody who's inquiring about hydrodissection is D5W should be the go-to, in our opinion. I think is that fair to say? And
yeah, it's been really nice seeing kind of the effect that it has and the success that we're getting with it.
Well, and the other thing too is the safety profile.
Right.
I mean, people fail to realize that when you inject a steroid around a nerve, if you get a little of that steroid inside the nerve, you've pretty well destructed that fascicle or a fascicle in the nerve. So, so there's a more of a safety protocol. Now, people will ask, what's the difference between glucopuncture and hydrodissection? Do you want to get into that a little bit? Because,
we try.
Okay.
Yeah, I mean, I guess from mine, you probably can explain this maybe a little bit better, but the glucopuncture is typically, I guess we'll say more like localized areas and more like fascial injections versus like around the nerve injections. So maybe trigger point might be an okay word to use, but more those fascial, technically you could use it for a joint, things like that as well, but more those fascial injections, like an insertional Achilles, plantar fascial, those localized areas of pain. I've been using a lot on like the plantar inferior like heel. There seems to be a very recurrent area that's responding really well to that there. So more just those fascial type areas of pain versus the nerve.
Right. And I think with hydrodissection, in glucopuncture, like you say, we're just trying to put it in the area, whether it's an area where they had a bad burn and the scars have created a local neuropathic problem for the patient. And it doesn't have to be done under direct visualization. Like a hydrodissection, you have to be adept at ultrasound because you're looking at things in real time, and that's a big deal. So, I think that increases the safety profile of hydrodissection. And I would not encourage people who are not adept in ultrasound to do that necessarily, where I wouldn't say that with the glucopuncture. So I think the glucopuncture is maybe more of an area where people that don't have experience with, interpretation of real time with diagnostic ultrasound, it'd be a little bit safer to enter the arena and play that game versus going right to the hydrodissection. So tell me about this case. and why I wanted to get this on the show.
You want me just a little overview that you want me to do for you before we dive
yeah,
into it?
yeah. So you and I were
Yeah.
talking a couple
Yep.
weeks ago, and you said, "Hey, I got this really cool thing." So tell me
Yeah.
what you. Yeah, it's awesome.
Yeah. So a patient that came in and originally presented with a drop foot and was referred to me by a colleague of mine that knows that I had this subspecialty. And so I did the initial diagnostic nerve blocks, and she had a little atypical response, but a response nonetheless. But I had done 2 hydrodissections on her, and she has a lot of chronic back pain issues. So she was actually going back to neurology to get an EMG to reevaluate her back pain that she was having. So her second EMG that she had prior to hydrodissection has showed that she had some entrapment at the deep peroneal nerve at the fibular neck. And after the hydrodissections that I did, it actually was showing signs of the nerve actually healing. So I hadn't done a decompression surgery on her. It was strictly hydrodissection, and I did do 2 of them when she had the EMG done. But there is actual objective findings that there is signs of healing on EMG.
Yeah, and that's why I think it's so cool that we present this, because it's always great when a patient will come back and they say, I feel so much better and that type of thing. Well, that's a subjective thing.
Sure.
But I mean, objectively, prior to you obtaining this case where there's true electrophysiological testing that shows benefit before and after, after your hydrodissections, that's very objective, very compelling. Another objective measure would be motor strength. But again, there's a little subjectivity in that with
Right.
What I call an improvement from 1 out of 5 to 3 out of 5. You may call it a 2 out of 5 to a 5 out of 5. I mean, so that, but from a neurophysiological standpoint, this is a very powerful objective assessment, which says, yeah, there, and I think the other thing that it says is that there is some durability to this intervention, which is important for people to understand, that there's a possibility that, hey, this could preclude you having to have surgery.
Right. Yeah. Yeah. It's exciting.
Yeah. All right. Well, let's
Okay.
share your screen and show us this case. You should be able to pull it up here.
All right. You able to see that okay?
Not yet. Now I've got it. Perfect.
Got it. Okay.
Yep.
Yeah. So this is my case, just benefits of the hydrodissection. So like a lot of the patients that tend to roll into our practice, there's typically a lot of history and all things that could potentially create some nerve symptoms, general term neuropathy, and she was no exception. So she was referred for that right drop foot was her main chief complaint. It was about 6 weeks earlier that came on suddenly for her. She had numbness. She describes that she had for years in both legs. She is diabetic, but has been fairly well controlled. Her most recent A1C was 6.2, and she had been consistently well controlled there. She has a diagnosis of hypothyroidism as well. A lot of chronic back, neck pain. She's had like old injuries to her neck, degenerative changes, low back and neck. But she's not a surgical candidate because she smokes. And so things are being managed conservatively. She was just primarily managed for the back and neck pain with medications, and she recently switched pain specialists. So she started getting some injections that I kind of mention as we go through this as well. History of carpal tunnel decompression. She's had 2 of them actually on one side, and then left cubital tunnel release as well. She continues to have.
Let me interrupt you there, because this is an important point.
Yeah.
Did she get improvement after her decompressions of the carpal tunnel?
So she actually still complains of like upper extremity weakness and still is dropping things.
Okay. The reason I ask that is there was a great publication probably around 2005. Chris Maloney and the neurosurgery group out at University of Arizona did a study, and they found that in patients with diabetic peripheral neuropathy with superimposed nerve compression, if they had a carpal tunnel decompression that was successful, they had 100% of the patients in that subcategory that had a successful lower extremity decompression. So for practitioners out there, that's a great question to ask people when you're working them up, because if they had that, then, and they got improvement, then you can you can pretty well bank on improvement after a lower extremity nerve decompression. So that, I don't know if you are aware of that article, but it's a great article that they did. I think it was 100 patients or something. So it was a pretty good patient population. Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor. I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called STEM Regen, which I take daily and genuinely believe could revolutionize your health journey as well. STEM Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. STEM Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating STEM Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that STEM Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of STEM Regen.
So she had her second EMG. So her initial EMG was actually more for her left side. The second EMG she had right before coming in to see me for that drop foot. The neurologist that had done it had stated that the EMG was abnormal because she had started crossing her legs. Patient states prior to the last year she wasn't able to, but she had just, for her, lost 100 pounds due to her thyroid issue. And then she states 6 weeks ago is when she was just walking, right foot stopped working as she describes it, and she fell. She states her legs will go numb periodically, but she has a feeling of numbness that's kind of chronically always there. And then she describes it herself as having diabetic nerve pain. She doesn't really talk about pain as much anymore. She still talks about the numbness even after we've treated. I included this is her last pain clinic note and essentially everything they're working on. So again, more just for completeness sake. And I think it's interesting the extent of her spinal involvement, but it doesn't, it's not apparent on EMG when we go through those.
Can we go back to that 100-pound weight loss
Yes.
for a minute?
Mm-hmm.
So there's a lot of literature that shows that there is a significant, and again, I haven't looked at the literature recently to give you an accurate percentage, but it's not uncommon after gastric bypass for people to develop common peroneal nerve entrapments, which is a really interesting thing. You know, I don't know why necessarily that happens, but it's consistent. So that may have been playing some role in her pathology as well.
I'm wondering with that, like, the weight loss, like if they're losing in their legs too, they might have that increased pressure with not having like adipose tissue for padding, or you know what I'm saying? Like there might be more of that osseous pressure.
That's something we should probably dig into and look at because they talk about it, but I've never seen an explanation of why it happens from a neurophysiological standpoint. But
that's interesting.
Yeah. Go ahead. I mean, this case is so good. I got to just jump in on some of these little points.
Yeah, there's a lot to I mean, she's one of these patients that has all the boxes checked. So she's a good one to present. But so this is just kind of the exam more or less that I go through. So I highlighted Some of the things that kind of change as we go through the treatment. So just to kind of highlight this, I always check all the nerves, but so the provocation sign, so palpating around that peroneal nerve was symptomatic, only on the right side, not on the left. Her other nerves as we go through were not symptomatic on the first exam. She does have an equinus also. Muscle strength, so dorsiflexion was weak on initial exam, a little bit decreased on the others, but EHL was 2 out of 5. So primarily her dorsiflexion and EHL were the main areas. And then again, the common for the main symptoms. She does have some kind of subjective decrease in testing and objective with the monofilament for some numbness that she describes. So this one I included for completeness sake. She was more left-sided dominant, so that was the extremity they were focusing on. And this was before the drop foot happened. This was in 23, so I think about a year before she had her drop foot. But they still call it an abnormal study, but kind of chalked up to polyneuropathy affecting both. And they were chalking it up more to the diabetic aspect and not anything to do with her back at that time. And then this was the second EMG. So this was right before I saw her for the drop foot aspect. So this is when there's the documented, again, it's changed from the initial, this one's now right-sided deep peroneal nerve entrapment at the fibular head and evidence of the demyelination and axonal involvement. So that's kind of the important points for where we get to after the hydrodissection. Again, just for completeness sake, I included her MRI, the last one that she had done, just showing some mild changes, L4 to S1 essentially, a little bit of L1 and L2 there too. So when she came in, I just did low volume diagnostic nerve block. She did not have a lot of change where most of the time we'll see that EHL kind of improving right out of the gate. She didn't have, I have to double check the muscle strength. More her numbness didn't change, which is what she was focusing on, but she was saying she didn't have much change. But then when I saw her back after the block, she actually had residual change instead of it being temporary day of. So she had more of a delayed effect, which was a little atypical. But she said she's able to move her ankle. She's demonstrating dorsiflexion better. Still has a feeling of numbness, which along the course of this, that perception has not changed for her. She says she's moving better. She will still get the drop foot with fatigue, but it takes longer for it to happen. Does not have pain. Again, no change in the numbness. So we started talking about treatment options on what she would like to do. She wanted to hold off on surgery, so we opted to try the hydrodissection first. So we did that at the peroneal nerve, ultrasound-guided. And her 1-month follow-up, she's about 25% improved that she reported, but she also says she's walking a lot better. She's not dragging her foot. But then she started noticing some discomfort mid-leg. So with re-examination, she now did have tunnels at the superficial peroneal nerve as well as at the deep peroneal nerve on the dorsal foot. So a little bit of change from that initial exam.
Do you remember how much you infiltrated?
I mean, like not much. I mean, usually less than a half cc.
Okay.
Yeah. Are you talking about originally or both or all the above?
No, I'm talking about for the hydrodissection.
Oh, for the hydro?
Yeah.
No, that's different.
Yeah, I was going to say.
The hydro was probably about at least 10 cc. She doesn't have a very big leg, so I think it was probably about 10.
Yeah.
Yeah. Nerve block was, much less, obviously. So I did repeat the nerve block at that follow-up visit. And again, for follow-up, she had good improvement the day of the block. She was at least 50% improved. Balance is still improved. The original hydrodissection. Tingling was still improved, moving toes better. But she has those additional nerve entrapment spots now that we decided to repeat the hydrodissection. So she's now 3.5 months after her first. I did repeat the common peroneal nerve. Symptoms hadn't significantly returned, but while I was doing it, I decided to do all 3 points of entrapment. And then 6 weeks after the initial, she's happy with improvement. She has not tripped since the second procedure, walking better, toes are moving better, still has a numbness again, that hasn't changed, but it's not painful for her. The pins and needles on her foot is better. She did get some initial leg cramps that she described initially, but resolved pretty quickly. And then we're 4 months out. Overall, again, still reporting that she's feeling better, 45 to 50%. She started doing some physical therapy. This is the timing when she has now switched pain specialists. So she's back in physical therapy for her neck and back, and now they've started doing some injections on her back as well. I did just see her this week, and she had some back injections, and she states there's no change in her injections when she gets them in her lower extremities. So I just verified that with her. She didn't notice anything there changing. So she is interested. She had a little regression, still improved from where we started, but she wanted to try the hydrodissection again. And again, we're just having that discussion on, do we do another hydrodissection to make it technically her third, or do we need to do something different for her? She's really been happy with the hydrodissection. So this is her third EMG now, and this is 4 months after the second hydrodissection. So just to recap, first hydro, I just did the common. The second one, I did common, superficial, and deep. And so this was the part that we're excited about, that they actually document from previously reported deep peroneal nerve entrapment at the fibular head, showing significant interval improvement with the intervention that was completed, including improving evidence of the demyelination and axonal loss. So that's the thing that I got excited about when I saw that report.
Yeah, so stop there for a second,
Yeah.
because this needs to be emphasized here, because, when we do things from a peripheral nerve standpoint, the question is always, well, what's happening with that nerve? What is going on? What is it regenerating, and that type of thing? And what you're seeing here is that this is demonstrative evidence of regeneration.
Yeah.
And that's what's so important with what you're showing with this particular case. It takes I'm not saying that you can extrapolate this out to all people that we're doing hydrodissections. Don't misinterpret what I'm trying to say, but I'm saying in this particular case, you're actually seeing nerve regeneration after your intervention.
Yeah. Yep.
That's pretty cool.
It is. Yeah. And I mean, the subjective with not having, the drop foot as much, not tripping as much, and then to kind of back that up, that there's a reason for it.
Right. Well, a lot can be said for just improving the balance and not tripping, because aside from the three bad actors that kill everybody over 65, I believe falls are right up there.
Yeah, absolutely.
So you made a big improvement in that patient's life.
Yeah. It's exciting. So yeah, she's doing well. And yeah, like I said, I just saw her this week. And so this week she decided to do the third hydrodissection. So she has a negative provocation. And again, just for consistency and the improvement that we had, I did do additional treatment there, repeated the superficial and deep. The interesting thing about her here is that previously she did not have any posterior tibial symptoms. And she is starting to feel that a little bit more now. So that's, for me, if that continues, or if that becomes a source of weakness, then for me, I would probably be talking to her a little bit more about the decompression aspect for that nerve. But her muscle strength has improved. So her dorsiflexion, again, a little bit slow to engage when we're going to test. It kind of takes her a little bit to do it, but then she is improving on her strength, that she has the ability to do it. But it's a little interesting that it's kind of slow for her to kind of get the connection to be able to do it. But her EHL improved quite a bit as well. And then they're doing more trigger point injections versus for more muscular and myofascial pain at the pain clinic versus anything kind of spinal related. But that's what they're doing, just to include that. I just included a little bit about kind of the hydrodissection and kind of a lot of what I have from your mentorship, and just kind of where my passion is kind of lied, that this is really becoming a large part of my day, is kind of nerve symptoms, essentially. So when I'm doing lectures for the students too, I kind of say, think nerve pain when, because it's usually the patients that say, is my pain real? Am I crazy? It changes a lot. It's hard to describe. So usually when that starts to be the chief complaint, that's usually I'm starting to think I'm going down a nerve path for what I'm assessing for. And just kind of the common causes of nerve entrapment that maybe always doesn't get the attention that it deserves is, maybe not thought of a lot, but a lot of sports injuries, soccer players. I have a patient that's a thrower, shot put discus in my office this week, a volleyball player, like a D1 volleyball player with some nerve entrapment. So those sports injuries, I think, maybe get a little underestimated, and really important to be assessing for. Any type of spurring, osteophytes to aggravate the nerve, especially in those points of entrapment. Our EDS patients, our hypermobility patients have that higher likelihood of having some nerve entrapment symptoms or traction compression from that hypermobility that they have.
And now a message from our sponsor. I've been taking Nature's Marvels bioregulatory peptides for more than 3 years now on a very consistent basis. It's an integral part into my wellness journey, and I can't imagine not even going on this journey without that. These are designed with cutting-edge science to optimize and restore your body's natural processes. After 3 years, I can say without a doubt, this isn't another wellness product that just gets pushed to the back of the cabinet. This is the real deal for human optimization and longevity. Start your journey today with Nature's Marvels. Our website's below.
Surgery, scarring, retraction, joint replacements. I didn't have that on the list, but an important one to mention. Right. And then direct injury, just getting hit in those, especially those points of vulnerability of going through those tunnels can create that. And then just altered gait, like one area hurts, they start favoring that area, and then all of a sudden the nerves compensating or getting that traction or compression across it to create some symptoms.
Tell people what EDS is, because they may not know.
So Ehlers-Danlos syndrome, so different subtypes, but essentially hypermobile of those joints, extremities, but also a lot of systemic process that can be affected as well. So patients that I find that are like hypermobile, then I start going down my review of systems if they have a lot of GI symptoms, things like that too, because they usually go together collectively. So a lot of them come in not having that diagnosis when they walk in, but when you start going through checking the boxes, a lot of times they kind of fall into those categories. So just, we kind of talked about this at the beginning, but just kind of what is hydrodissection? So injecting that 5% dextrose, separating those tissues away from that nerve to alleviate that entrapment. That dextrose can promote some healing. And then the benefits of the hydrodissection. So some things in theory are some things that are where we anticipate what it's doing, but alleviating that pressure on the nevi nivorum and vasa nivorum. That's something, you and I have gotten to see when we're doing the surgeries of the decompression, actually seeing that vasa nivorum kind of coming back around the nerve, which is always an exciting thing that doesn't get old to see. But if that's truly what, the hydrodissection is doing, I mean, that's how the nerve is getting those nutrients, again, to help promote healing as well.
Yeah, and for the audience that may not be nerve people, vasa nivorum is the blood supply to the nerve itself, and nevi nivorum is the nerve supply to the nerve, which is kind of, think about that. It's like my nerve has nerve,
Right. Yes. I know. Something we don't think about a lot, but
no.
Yeah. So then just that glycopenia kind of theory of, if a nerve doesn't have that energy source, it can create those neuropathic symptoms. And then in blocking the substance release of that substance P. So that was the receptor, the potential vilanoid receptor is what was referenced as far as where that substance P is getting blocked to have that effect as well. Always, for those that are thinking they want to start going to this, I just, want to make sure you're not injecting into the nerve with any of your nerve blocks or hydrodissection, so you're not causing more damage. Just always something really important to be mindful of. And then just kind of patient education. They'll kind of feel a temporary pressure initially, but usually when they leave, they feel pretty good. They're usually like, hey, this feels better already. Right. And then I usually tell them there might be a little delayed effect for that lasting. But usually most people feel pretty good when they leave.
Yeah, that's been my experience as well. It's actually, believe it or not, a very innocuous, comfortable technique if you know what you're doing. Patients are surprised, like, wow, that didn't hurt.
Right.
So.
Yep, exactly. Yeah. So that is all I had.
Well, like, that's not enough, right?
Unpacked a lot there.
Yeah, exactly. Right. So let's see if we can go back to the regular screen. Great. So I think this case is great, not only from the standpoint that you have objective neurophysiological testing that shows that the nerve improved, but also it showed that this was over a course of time. I mean, you gave the first one, and then I think it was 3.5 months. And then the second one was maybe another 4 months after that. And then the third one was another few months, so it's showing that there's some durability to your intervention.
Yeah.
This is just off the top of my head because we're still trying to figure this out. I mean, in peripheral nerve, there's still a lot of exploration. It's kind of an unexplored frontier in hydrodissection with D5W. what's your thought processes of in between the hydrodissections, allowing for some glucopuncture along the way?
Yeah, that's an interesting thought, just to, yeah, especially if there is,
I don't see any downside to it.
No. And I've, incorporating like a pain laser, that's kind of what I've been doing with my glucopunctures, and help reduce some of that surrounding swelling too.
Right. Now, and then the other thought that has come to my mind over the last, I don't know, X amount of months is that there's certain times when you just have to go right to the nerve decompression. It's just, based on the clinical presentation of that particular patient. But there are a lot of I have a lot of thought that, if you intervene with a hydrodissection, it's a very benign, very safe technique. And let's say you only get 50% response, where 50% of the patients have a substantive improvement. That's still a big win, because you haven't put a patient through a long journey with like a surgical intervention.
Right.
So I don't see any downside to adopting more of a conservative approach before we go ahead and go with, a nerve decompression surgery. But, just the thought process is, and this may be erroneous, I don't have anything to support this, but I'm just, thinking outside of the box a little bit, is like, well, certainly it's going to give the nerve a little bit more energy, so that if you do end up doing the nerve decompression, you might have a more receptive host.
Right.
So you see what I'm saying is that, well, maybe we didn't win with that hydrodissection for this patient from the standpoint that we had to prevent them from having a nerve decompression surgery, but maybe we, upregulated their nerves so that they can actually heal better after the nerve decompression. Have you ever thought about that?
Yeah, I have. I think there is something to it. I mean, the fun part about nerve decompression is patients usually feel so good initially that, it's just one of those things. But even if you're kind of setting the stage for that nerve to be like feeling better quicker type of thing, I think there's definitely something to that.
Right. I think as more of this gets presented, particularly at the Association of Extremity Nerve Surgeons, and there'll be more, adoption of this technique. And when more people start doing it, more people will report more results, and then we'll be able to take things and maybe form better protocols and that type of thing. But I think it's a very exciting thing.
Yeah.
So I think this case was great because it brought up so many different things. Like, all right, so one of the things that you brought up is that she got better from a motor strength. She got better from a nerve conduction study, but still has this residual symptomatology of maybe pain and numbness. And I think Dr. Alvaro, and so he was telling me a couple months ago about a study that they're getting ready to publish, or it's submitted. I don't know the process of it, but they had like 50 patients where they did tarsal tunnel decompressions, and they looked at 3 months, I believe it was, gave everybody an EMG, and 100% of those 50 patients had electrophysiological improvement. But only, and the numbers I'm going to say are not the actual numbers from the study. I'm just saying it for purposes of discussion, not accuracy. So if somebody reads this article when it comes out and I said 35 people still, or 35 out of the 50 got better, it's somewhere in that neighborhood. But a significant percentage of the 50 still had continued pain after they had done the surgery, but yet the nerve showed a normal nerve response on the EMG testing. And so the conclusion is that sometimes this is probably just centralized pain. And it's not anything that the surgeon did. The patient's going to come back and say, well, why, I can wiggle my toes more and I have a little bit more sensation, but why do I still have pain? You didn't do the right job. And the answer is no, they did the right job. The nerve got better. It's just there's something, and it's a very complex system between the peripheral nerve system and the central nervous system. And so there's something going on centrally that it's a sensitization, or there's something going on that we don't have control over from a peripheral standpoint.
Yeah.
So I think that's something that it just kind of tickled my imagination, that it's better for the patient to understand that they still, even though it's a very successful surgery, that they still could still have remaining symptoms.
Well, I think it kind of reflects a little bit of the case too, that, I mean, there could be another source of pain. Like it might, maybe it's centralized, maybe there's another peripheral source. So that's whenever we're going through these and working up these patients and they have like 4 spots and I'm trying to educate the patient, like you got multiple areas. Not all these areas might be the source of your pain, but they're all a little fired up right now. So when I'm talking through that, it's like, you knock out 2 and it's like a lot of times it gets better. But then they might come back and be like, well, I'm not better. Like their perception is they aren't better. But then you re-examine like, hey, here's the pre-op exam or pre-treatment exam and here's the post. Look at all the things that are better. We just still have more work to do. Right.
And I think that's, another benefit of hydrodissection is that it allows you to learn more about the patient.
Right.
Because these patients are highly individual. They may have different things going on. And once you learn about certain things and, maybe they're under inordinate amounts of stress. And if you just see them and take them to surgery and then follow them up for a few visits post-operatively, you don't really get a chance to really get to know them. Whereas with hydro over a period of time gives you a little bit more of an insight into who that person really is, who that patient really is.
Right. Yeah. I mean, it's like a lot of this patient's just nice because it shows a lot of what we see, the complexity of it. It's not simple. It's probably multifactorial. But if I can at least help with a portion of it, that can be a win. So
no. Well, and then the other thing is that a lot of times if you identify 3 or 4 or 5 pain generators and you address 1 or 2 of the most significant and they get better from those, then the body can get ahead of the curve. And then all of a sudden, 6 months down the line, the patient will say, yeah, I'm doing pretty darn good now.
Yeah.
So you got to just give it some time sometimes. And the body is miraculous in how it can respond to things and just take a couple of things off the plate. And then all of a sudden you see good things happen. So
absolutely.
That's awesome. Tell people where they can get a hold of you and where you are. And so I'm in Ames, Iowa. So my practice is foot and ankle specialist of Ames. Our website is fas-ames.com, and there is an email that is on there, info@fas-ames.com, if they want to get a hold of me. Well, Erin, I'm a big fan of yours. I think you're a true rock star coming up the ranks, and I'm very proud to know you and have you as a friend and colleague. And I can tell anybody, I refer you patients all of the time that reach out to me that are, up in the Midwest and the frozen tundra area of the planet. But yeah, no. And so I want to thank you for coming on and sharing your time today. And I encourage anybody, if they're looking for a great lower extremity peripheral nerve surgeon, to reach out to you.
I appreciate that. And definitely appreciate your mentorship over the years. And I wouldn't be where I am now without you. So I appreciate that over the years.
Well, that's very kind. I think you'll have to buy the drink at the nerve meeting then.
Deal.
All right. Well, folks, if you are over 40 and you are not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to the health of so many bodily functions, not the least of which is cardioprotection. If you have any question on nitric oxide, I suggest that you register with Approved Medical Solutions and begin receiving their educational emails. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, Approved Medical Solutions created the only nitric oxide replenishment formula without oxalates. Approved Medical Solutions does not use beet, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you'll receive a 10% medical discount savings. You can register to receive educational emails without any purchase. For licensed practitioners, you too can go to approvedmedicalsolutions.com and get registered today. They have unique bundles for all of the full-fledged spelunkers of the plot of inquiry. Use Pod of Inquiry at checkout after registration. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see every one of them be deficient. When they see this result, they will want you to start them up immediately. Now, thanks to approved medical solutions, you can give them the best care without the worry of oxalates. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.